This conference will now be recorded.
Okay, last class we were talking about this antiretroviral drugs, right? So in this antiretroviral drugs, we have learned about each and every slide, each and every drug and every group of drugs. Now the total thing is now how we have to treat the patient, you have to know. Okay, so as in the last class I have told you in the first slide itself, the efficacy of the drugs is calculated by the CD4 counts and the viral load. Okay, that is HIV viral HIV RNA per microliter of the plasma. Okay, so they have designed this highly active antiretroviral therapy, simply called as HART therapy. Okay, highly active antiretroviral therapy. So their main point is they have to inhibit the viral replication. Okay, so what happens normally, HIV virus when it enters, it will attack the immune system. So if we are inhibiting the viral replication, the immune system, further damage to the immune system can be stopped. Okay, so that is what, so we are preserving the immunity of the human being by giving this antiretroviral therapy. Okay, so thereby what happens, if the further invasion of the CD4 lymphocytes is stopped, so we can prevent the transmission of the disease also. Okay, so that is the main point of this HART therapy. We are inhibiting the viral replication and thereby we are preventing the transmission of the disease from one human being to another human being. Okay, so we are one more thing is highly active antiretroviral therapy. This antiretroviral therapy should be very highly active, means we are giving drugs which are acting at different sites of viral replication. Okay, so when we are giving 2 or 3 drugs which are acting at different site of action, what will happen, the virus cannot develop resistance to all the 3 or 4 drugs at the same time. Okay, so thereby we are preventing the emergence of drug resistant virus. Okay, and also the main the main point is we are inhibiting viral replication, so we are maintaining the effective immunity of the human being, and we are also preventing the emergence of resistant strain, and we are also preventing the transmission of the disease. Okay, normally previously what happened was, when we are when to start the therapy was, we used to count the CD4 count. Okay, normally before 2016 guidelines, they thought like CD4 count, if it is less than 350 cells, then we'll start the antiretroviral therapy. But now what happened, they have observed that if the CD4 count is good, but still what happens is the virus is present in a latent form in some of the immunity cells, and after some time when we are stopping this antiretroviral therapy, it is giving a relapses. Okay, so thereby suddenly the viral replication will start, and thereby suddenly the immunity of the cell is damaged, immunity of the host is damaged. So the ultimate point is, when to start HART therapy means, once the patient is diagnosed with HIV positive means, we have to start the therapy, whatever thing is there. So all HIV positive patients, including the adolescents, children, the pregnant women, the breastfeeding women, irrespective of the CD4 count and the viral load, and you have to start as soon as possible after the diagnosis is done. Okay, this is the guidelines given by the World Health Organization in 2016, and it is accepted by the NACO in India also. Okay, so if previously what they used to do, breastfeeding women means we have to see the risk and benefits, pregnant women also we have to assess the risk and benefit, then they used to give the treatment. Now it is not like that. Once a patient is diagnosed HIV positive, you have to start the therapy. Okay, now the regimen principles, how they have designed this HART therapy, highly active antiretroviral therapy. Okay, initially just like tuberculosis, the HIV also they have started with one drug, either zidovudine or lamivudine, like that. Okay, but what happened, the emergence of resistance has started, so they are giving 3 drugs. Okay, and all the regimens should have at least 2 nucleoside reverse transcriptase inhibitor plus 1 non-nucleoside reverse transcriptase inhibitors. Okay, why we are preferring 2 NRTs and 1 NRTs means, NRTs, they are not inducers or inhibitors, and they don't have drug-drug interactions. Whereas NNRTs, if you remember in the last class I told you, NNRTs, they can be either inducers, either they can be inhibitors, or they can be mixed inducers and inhibitors. So if you are giving 2 or 3 drugs means drug-drug interactions will take place. Either it may result in toxicity, or it may lead to decrease in the efficacy of the regimen. So we will prefer 2 NRTIs and 1 NNRTI. Okay. And the NRTI is what we are preferring now. These are the new guidelines, 2016 WHO guidelines. According to this, either will give lamivudine or abacavir or tenofovir or emtricitabine. Okay. These 4 drugs are the first choice drugs in the NRTIs. Lamivudine, abacavir, tenofovir, emtricitabine. Previously, it is used to be zidovudine. Okay. Now it is replaced because of development of resistance to zidovudine. Now the NNRTI, we always prefer efavirenz, okay, and etravirin. If the patient is not responding, then only we'll go for the etravirin, okay. Nevirapine is totally avoided now because of hepatotoxicity, and also most of the HIV patients, they are having concurrently tuberculosis also. So because of this thing, nevirapine is most of the times avoided, okay, and especially if the patient is having rifampin means don't give nevirapine, okay. And in pregnant women, efavirenz should not be given, or if the woman is planning for pregnancy also, you should not give efavirenz. Now, 3 drugs from 2 different classes, I told you, 2 NRTIs and 1 NNRTI. Now, there are thing called protease inhibitors. These protease inhibitors, if they are included, they are called protease inhibitors regimens, and if they are not included, they are called protease inhibitors sparing regimens, okay. Now, if the new patients who are diagnosed with HIV recently, they are given always protease inhibitors sparing regimens. Okay, this is also because of the drug-drug interactions only. Okay, now there is 2 more drugs I told you, integrase inhibitors, maraviroc and raltegravir. In the raltegravir group only, there is one more new drug called dolutegravir. Okay, in this dolutegravir, it acts on both HIV-1 and it acts on both HIV-2 also. Okay, it acts on both HIV-1 and HIV-2. Okay, actually these are costly because these are new drugs, but if the cost doesn't matter in the countries like developed countries, then you can go for this raltegravir and dolutegravir also. Okay, and raltegravir is preferred only if it is HIV-1 infected patients, and dolutegravir is preferred if both the strains of viruses are there. Okay, because why we try to prefer this means what do you say, actually whatever we are giving these 3 drugs, we are given in the fixed dose combination. Okay, so when we are giving these NRTIs and NNRTIs, yesterday in the class I told you, either you will give 4 times a day or 3 times a day. Raltegravir, dolutegravir once a day. Okay, so because of this, what is happening, the patient will take the drug once a tablet is always better than 4 times a day tablet. Okay, so because of this, discontinuation rate of the treatment will be decreased. Okay, or in simple words, patient compliance is improved. Okay, patient he himself will go and take a tablet if you are decreasing the pill burden on the patient. Okay, so the discontinuation rates will be decreased. Okay, now if high viral load patients are there means we'll go for this combination abacavir, lamivudine and dolutegravir. Okay, why high viral load dolutegravir means lamivudine, abacavir are very high efficacious, and dolutegravir this is because it acts on both the strains and efficacy is more, and abacavir, lamivudine we'll prefer only in high viral load because of this severe toxicity. Okay, and next another choice, if still this abacavir, lamivudine if we can't give because of the pancreatitis or anything is there, then we'll go for a combination of tenofovir, emtricitabine and efavirenz. Okay, now the protease inhibitor regimens where protease inhibitors are included, those are used only for advanced cases, means already they have been treated with some other drugs and there is no improvement in the patient and the regimen has failed. Okay, or we can say if the resistance has developed, then we'll go for the protease inhibitors regimen. Okay, remember always, it is not like TB. TB will give for around 12 months to 24 hours, something like that. But here, this HIV, it is a lifelong therapy. Why? Because the virus will always be a latent infection. Okay, so if you stop the treatment, the virus will start giving a relapses. Okay, after some time, like after 1 year or 2 years, again it will start giving a relapses. Okay. If at all side effects are being developed for these drugs, you should not reduce the dose, because the efficacy once it is decreased means, the dose is decreased means the efficacy will not be there, but we are giving a chance for the virus to get exposed to this drug and the virus will start developing resistance. So you should never reduce the dose always in the multiple regimens. Okay, only you have to replace the drugs. That is the only choice is there if any side effect is developed. Okay, in pregnancy, which drugs are preferred means zidovudine, lamivudine, tenofovir, emtricitabine, efavirenz, nevirapine, and nelfinavir. Okay. And there is one more thing called during this treatment, you can develop a side effect called IRIS, that is immune reconstitution inflammatory syndromes. Now, what happens is we have given treatment and the patient, there is immunity system is good. But what happens in certain latent, in certain CD4 cells, still this virus will be in a sleeping stage. Okay. And there will be opportunistic infections, HIV patients, because immunity is suppressed, more opportunistic infections like fungal infections or TB, those things will develop more in these patients. Okay, if those opportunistic infections are partially treated, or if the patient has stopped the treatment because he feels that he is well and there is no infection. Okay, in those cases, when we are giving this ART, we are suppressing the immunity because of this all these things. What we are doing, we are building the immunity in these patients by giving the ART, antiretroviral therapy. But here what happened, these opportunistic infections are partly treated and the latent infection is also there. That is latent HIV infection is also there. Suddenly we are developing immunity in these patients. Okay, now this immunity, it will see this latent HIV virus in those CD4 cells, and also it will see the fungal or TB bacteria or whatever those bacteria it will see, and it will start developing reactions on those cells. Okay, now you will see an inflammatory reaction. Okay, so that is why it is called, we are reconstituting immunity, and because of the immunity development, an inflammatory process will develop. So that is called IRIS, immune reconstitution inflammatory syndrome. Okay, so this is a 2 marks question for you. What is the treatment side effect means IRIS. Okay, see, these are all the snapshots I have taken and I have directly kept here. Why means these boxes are very, very important in your Tripartite textbook. Okay, so to make you people realize that these boxes are important, you have to keep a star mark or something in the textbook and you have to read these boxes. Okay, so first line, antiretroviral regimens for adults and adolescents. What are the guidelines according to WHO newer guidelines 2016 means first preferred regimen will always be tenofovir, lamivudine, and efavirenz. Tenofovir, emtricitabine, and efavirenz. Because these 3 drugs are safer in pregnancy and breastfeeding women, it is given in adolescent, pregnancy, and breastfeeding women. Okay. Alternative regimens are zidovudine, lamivudine, efavirenz, or zidovudine, lamivudine, or nevirapine. Okay, these can also be given in the pregnancy and the breastfeeding woman. Okay, the first two in both the columns you can give. Okay, in pregnancy and breastfeeding women. Okay, or otherwise, see if you can see here either lamivudine or emtricitabine is there. Okay, in this NRTIs, zidovudine or tenofovir is included, and there are combinations where you have preferred this dolutegravir or nevirapine. Okay, so that is how these combinations are designed. Okay, so only 3 drugs are there here, tenofovir or zidovudine in the first line, and in the second one either lamivudine or emtricitabine, and in the next NNRTIs either efavirenz or nevirapine. If you want to add an integrase inhibitors, you will give a dolutegravir. Okay, that is how the treatment regimens are reconstituted. If the first regimen has failed, okay, that is zidovudine, lamivudine, nevirapine, or tenofovir, lamivudine, or nevirapine, we'll go for the second line regimen, where in the second line regimen, we'll give a protease inhibitor also. Okay, in the failed regimen, we'll give a protease inhibitors also. Here, this is according to the NACO guidelines in the 2013. Okay, here the choices are, in the NRTI component, we'll give a tenofovir and abacavir, and protease inhibitors will go for the atazanavir or ritonavir. Okay, the bar R is ritonavir. Okay, and if tenofovir is not preferred because of any side effects, or if the patient is at risk for side effects of tenofovir and abacavir, we'll go for didenosone or abacavir with the protease inhibitor lopinavir or ritonavir. Okay, the third choice will be tenofovir or zidovudine or lamivudine with saquinavir or indinavir or nefirinavir. Okay, these are the combinations. And I know this is difficult, but you have to remember all drugs here and you have to remember all the regimens also. Okay. Now, how can you tell that the regimen has failed? Here I have told you, like, if the regimen has failed, you'll go for the second line regimen. How you will assess the regimen has failed? Okay, you will do the CD4 count and you will do the same plasma HIV RNA count. Okay, if the plasma HIV RNA count after giving treatment for 6 months, if they are still detectable, okay, or if they are still detectable, then you have to say that the regimen has failed. Okay, normally not detectable means it should be less than 50 copies per microliter. Then only will say that the HIV RNA count is undetectable. If that count has not reached within 6 months of treatment, you say that the treatment has failed. Okay, and if repeated detection of virus in plasma after initial suppression to undetectable levels. Okay, first initially the test is done, it is undetectable, but again after 1 month, every 1 month you have to do the test. If you are doing the test after the continuing the drug regimen, and if you see that the virus load has increased, then you will also say that is the treatment has failed. Okay, another one is CD4 count. Despite giving the treatment, if the CD4 count is still falling, okay, even if it, then you have to say that the treatment has failed. Okay, and also clinically, how you can say this means if the opportunistic infections are increased or serious opportunistic infections like cryptococcal meningitis, candidias infections. Okay, so while still the patient is on drug therapy, still serious opportunistic infections are there like meningitis, then you will say that clinically the regimen has failed. Okay, if any of these three are detected, you have to go for the second line regimens where protease inhibitors are included. And here what are the regimens here? Okay, second line regimens, 2 NRTs, 1 protease inhibitors, as I have said, and zidovudin, lamivudin will be the backbone of all the second line regimen. Okay, and there will be always a fixed dose combination of ritonavir tablet along with darunavir, which can be used as an alternative PI. Okay, either ritonavir or darunavir, we can give an alternative. Okay, there is one more integrase inhibitor, that is raltegravir. If it is included along with lopinavir, that is alternative regimen. Means here we are not including NRTIs, we are including integrase inhibitors along with the protease inhibitor, either lopinavir or ritonavir, and this regimen can also be used. Okay. Now, antiretroviral drug combinations which have to be avoided. Okay, this is also a table which is there in your Tripartite textbook. Okay, zidovudin, stavudin, if you are giving, it will cause pharmacodynamic antagonism. Okay, pharmacodynamic antagonism means both of them are acting at their site of actions. Okay, this zidovudin and stavudin. Okay, there is no point in giving a drug where both of them are having pharmacodynamic action. Means the same mechanism of action is there, no use. Okay. Then next one is stavudin plus didanosone. Stavudin will neuropathy and lactic acidosis. When both of them are acting together, it will further increase. Both of them will act together and increasing their side effects, but not in increasing their efficacy. So this combination is also totally avoided. And next, lamivudin plus didanosone. Clinically, they are not additive. Means 1 plus 1 is not equal to 2 here. Okay. So there is no point in giving this two combination again. Another one, tenofovir plus didanosone, efficacy is very less if you are giving this combination. Okay, 1 plus 1 is less than 2 here. Okay, and next, lamivudin plus amitriptyline, both of them are same drugs. I mean similar group of drugs. There is no point in giving similar group of drugs here. Okay, this is a most common 2-mark question. Now there is something called pre-exposure prophylaxis and post-exposure prophylaxis. Okay, so pre-exposure prophylaxis means before exposing, and we know that the patient is HIV patient, and we know that we are getting exposed to the patient, like the risk groups, the men who are having sex with the men, okay, and the sex workers, their occupation is sex workers, and they know that they are getting exposed, and injection drug users means drug addicts peoples where they are taking repeated injections. What they do is they don't use the same personal syringe. They use the same syringe for all the group of people who are taking the drugs. Okay, and the transgender people, both lesbians and the homosexual people, and the uninfected partners of the heterosexual serodiscordant couples. Means there is a couple, heterosexual people, and one person is positive and the other person is not positive, and if they are having sexual intercourse, then what happens, there is a chance of the uninfected partner to get infection. So to prevent that, pre-exposure prophylaxis, we will take they can take this tenofovir 300 mg daily with plus or minus emtricitabine 200 mg daily. Okay, this is according to the WHO 2016 guidelines. Okay, and type of exposure, high risk exposure, low risk exposure, and no risk exposure. Okay, you have to know this thing, because you will get, you should know yourself, like who are high risk and who are low risk. According to the division only you can give the drugs here. Okay, so high risk exposure means the source will be symptomatic HIV patient. Okay, and the ideal HIV viral RNA load will be very high, or people only see your post app. Okay. Post-exposure prophylaxis, after seeing who are high risk group people, high risk and lower risk and all these things. After that, you have to know what is a post-exposure prophylaxis of the HIV infection. This is different for adults and adolescents. It is different drugs, and for children less than 10 years also it is different drugs. Okay, we'll always here also we'll give a combination. Either we'll give a combination of 2 NRTIs, or we'll give a one protease inhibitors, or alternative third drug which is an integrase inhibitor. Okay, so preferred 2 NRTIs will be either tenofovir or tenofovir plus emtricitabine. Daily we have to give once, and preferred protease inhibitors will be lopinavir or ritonavir, or atazanavir or ritonavir. Okay, it's a combination of 400 plus 100 mg lopinavir 400 and 100 mg ritonavir, and atazanavir 300 mg plus 100 mg. Okay, with the ritonavir 100 mg. Alternative third drug will be darunavir 600 plus 100 mg ritonavir, or raltegravir 400, or efavirenz 600 mg. Okay, whatever this which is suitable to the patient, we'll give this drug. And for the children less than 10 years, preferred 2 NRTIs. This is always preferred. First one, preferred 2 NRTIs, zidovudine plus lamivudine. And alternative 2 NRTIs will be abacavir or plus lamivudine, or tenofovir plus lamivudine, or emtricitabine. Okay, protease inhibitors always same, lopinavir and ritonavir. Okay, third drug will be the same, integrase inhibitors will be added to this atazanavir or efavirenz, darunavir or raltegravir, whatever will be adding that. Okay, duration of regimen will be for 28 days, that is 4 weeks. Okay, this was the before 2016. This was the guidelines which was used. Zidovudine, lamivudine twice daily for 4 weeks. Zidovudine, lamivudine, or rendinavir. But this is no more used being now. Okay, this is the drug we have to give. 2 NRTIs or protease inhibitors, or alternative third drug can be used. Okay. Now, perinatal prophylaxis of the HIV means we are trying to prevent the transmission of HIV from the mother to the baby. Okay, means the mother is HIV positive, and during the pregnancy, if the mother has developed the HIV infection, we are trying to prevent the HIV infection from the mother to the baby. Okay, now what we have to do is during the pregnancy, we have to give a fixed tablet of tenofovir 300 mg plus lamivudine 300 mg plus efavirenz 600 mg tablet. Okay, this is a combination tablet where you can take once daily, continuously throughout the pregnancy should be given. And after the delivery of the baby, we should make sure that the baby should not get exposed to the amniotic fluid for a longer time. Okay, and to the blood of the woman for a longer time. Okay, and because the amniotic fluid is infected and the baby gets exposed to the amniotic fluid, we will always give nevirapine syrup for 6 weeks for the baby. Okay, why we will prefer why means nevirapine, this is a NRTI, and NRTI, what happens is the baby immune system will be being developed, and when we are giving this, the immunity cells will not get infected with the HIV. Okay, that is the ultimate concept of this point. Okay, after birth only the immune system cells will be developed. So if the HIV, once after the birth only the HIV viral replication takes place in the baby. So if you are giving this nevirapine syrup, we are preventing the multiplication. So there are high good chances of the baby not getting infected. Okay, and delivery is always preferred by cesarean section if the HIV RNA copies are more than 1000 copies per microliter at the time of the delivery. Okay, means the HIV viral load is very high, so you should not go for the delivery through the normal pregnancy. It is always preferred by the cesarean section. Okay. This is actually protocol how if it is detected HIV positive during blood finger pricking at the onset of labor, single dose nevirapine plus as I have told you, every 12 hours during labor and delivery, mother and baby should always continue. Okay, all infants nevirapine for birth for minimum 6 weeks. Okay, and mother should be linked to the ART center for initiation of the ART and ARV prophylactic regimen at the earliest. Okay, this is when the woman is detected HIV positive during the labor. Okay, so it is always mandatory for the woman to get tested with the HIV at the labor. Okay, previously they might not be get infected, but during the labor also they might get infected. Okay, so that is about the HIV class. Okay, the regimens are very important. It is So these regimens are very, very important. These are mandatory. You have to